Okay. So, ready? Inshallah. Today we'll talk about blood supply to the heart. Is this included in the midterm? No? By the way, yesterday I sent all the questions for the final because I'll be traveling soon. But all the questions will be from this lecture for the final. I will not include questions from the pre-midterm material. Okay? Just don't tell anyone. Let's keep it a secret. So all the lectures, all the questions for. Anyway, so pay attention and all the questions will come from this lecture. And the questions for the midterms are really easy, inshallah. So, what is... What is this? Coronary artery? What is this? It's a semilunar valve, right? How do I know this is the aortic or the pulmonary? Two things. Yalla, we're the smart people. Okay, so the orientation of the valves, pulmonary has right and left and anterior. And the aortic has right and left and posterior. Is this important? And you will know, inshallah, soon it is important. What else? How do I know this is the pulmonary valve? Huh? How do I know this is the pulmonary valve? Both will have. This is the aortic, right? Because what you see behind the aortic sinus, the pocket, you have the openings of the coronary arteries. So this is the origin of the two coronary arteries. So when do they actually receive blood, these coronary arteries? During contraction, or ventricular contraction, or ventricular relaxation? And during systole or diastole? Yes. Why not during systole? Yeah, because during systole, these cusps, blood will push them and will close the openings, right? While during diastole, there will be negative pressure, and blood will come back, will fill these sinuses, and will go through the coronary arteries, and the valve will close. Clear? Clear? Okay? Right. So the origin of the right and left coronary arteries, they come from behind the aortic valves or the aortic sinuses. Let's start with the left coronary artery, as you're going to see here. The left coronary artery, as soon as it emerges from the aorta, is going to divide into two. Immediately, it's going to divide into two arteries. One is going to descend in the anterior interventricular sulcus, and we're going to call that anterior interventricular artery, or the left anterior descending artery. So this one here is the LAD, L-A-D, left anterior descending, or the left interventricular artery. The other one that's going to circumflex the heart, is going to go around the heart and it's going to run in the coronary sulcus. So the left coronary artery is going to divide immediately into two. One is the left anterior descending, and the other one is the circumflex. Now, from the left anterior descending artery here, you can see it is running towards the apex. It's the main artery that will supply the apex. Okay? Now, not only it's, arteries, they are like rivers. They're going to supply right and left. So from the LAD, it's going to supply the two ventricles. And it's going to give us some diagonal branches, artery or artery. Sometimes they come from LAD or they come from the main one. But also, it's going to supply the interventricular septum. It's going to supply the anterior 2/3 of the interventricular septum. Okay, so it is extremely important, and this is the commonest artery to be affected by atherosclerosis or arterial closure. Okay? Now, the other artery that will come from the left is the circumflex artery, and as the name implies, it's going to circumflex the heart. It's going to run around the heart in the coronary sulcus. Before it winds around and goes posteriorly, it's going to give us the left marginal artery or arteries. These two arteries here could be one or more. We call them the marginal arteries. So again, left coronary artery coming from behind the cusp, the left cusp of the aortic, of the aorta or the aortic valve, the aortic sinus. It's going to run for a short distance, and then it's going to immediately divide into two, left anterior descending or the anterior interventricular artery, and the other one is the circumflex. From LAD, it's going to give us some diagonal branches, one or two or more. Sometimes they come from the main artery here. And it's going to supply the anterior 2/3 of the interventricular septum. And it's running toward the apex. It's the main artery that supplies the apex of the heart. And it's, again, like a river. It's going to supply both ventricles. Now, the circumflex is going to go around the heart, and it's going to here, right? You can see it just underneath the coronary sinus, and it's in the coronary sulcus, winding around the heart. Before it winds around the heart here, it's going to give us left marginal artery or arteries. And this is cardiac catheterization. You know how they do it? They go through the femoral. Recently, they do it through the radial. They keep going up until they reach the aorta, and then they will inject a dye, and they start taking pictures. So if the dye goes normally and flows within the arteries, then the arteries are fine. If the dye does not continue, it means that there is a blockage somewhere. So this is the LAD, and this is the circumflex artery with its marginal branches. Okay? Now, again, this is the circumflex. It's running in the coronary sulcus, just underneath the coronary sinus. So the left coronary artery is responsible for supplying the left side of the heart, the left ventricle, and it's going to give us many branches to the left atrium. So the whole left side of the heart is supplied by the left coronary artery, except the area close to the septum here, as we're going to see later on. Now the second artery is the right coronary artery. Right coronary artery is going to emerge from behind the right cusp of the aortic valve or the aortic sinus, and it's going to run into the coronary sulcus. Again, while running, it's going to give us arteries to the right atrium, and it's going to give us arteries to the right ventricle, and it's going to wind around the heart. It's going to go around the coronary, around the heart in the coronary sulcus. But before it does so, it's going to give us right marginal artery. So it's going to supply the right ventricle, the inferior surface of the right ventricle, this right marginal artery. both surfaces actually of the ventricle. And then the right coronary artery is going to wind around the heart opposite to the circumflex. Circumflex will come from here, and this is the right coronary artery, and they anastomose with each other. What is the advantage of arterial anastomosis? Is that a good thing that our arteries anastomose with each other or no? It is a good thing, because if one artery is blocked, that area will be supplied by the other artery. That's why myocardial infarction or ischemia of the heart is really bad when it affects young people, because they don't develop enough anastomosis. As you grow older, you will develop more anastomosis. So this is the right coronary artery. It's coming from here in the coronary sulcus. It's going to wind around the heart, and it's going to anastomose with the circumflex. But before it does so, it's going to give us this artery. In most of people, 80 to 85% of us will have this artery coming from the right coronary artery. It's called the posterior interventricular artery, or posterior descending artery, or PIA, posterior interventricular artery, PIA. So, and it's going to supply the posterior 1/3 of the interventricular septum. Now, the anterior 2/3 is supplied by LAD, while the posterior 1/3 of the interventricular septum is supplied by PIA. Okay? والله الليزر إذا اشتغل، إذا الله خلاه، ما أعرف إيش المشكلة، بس مو شغال إلا إذا في هنا واحد ثاني. إيه؟ ما تشوفوا الماوس؟ أشر لحالي يعني كنت صار لي ساعة. نبدأ من الأول. لا طبعا ما حبنا من أول، أنا ما صدقت أخلص الفيديو هنا. طيب، but يعني briefly صار تدلل ها. So briefly, this is the left coronary artery. Okay, coming from behind the left cusp of the aorta. After short course, it's going to divide into two. LAD, left anterior descending artery, running in the anterior interventricular septum, and it's going to supply the anterior 2/3 of the interventricular septum. Now remember, in the interventricular septum, it has two parts, right? Muscular and membranous. What's in the membranous? Huh? AV node أنت الامتحان انتو؟ Huh? Bundle of Hess. So if you have ventricular septal defect and there is a defect in the ventricular membranous interventricular septum, what are you going to have? Arrhythmia? Huh? When there is no conduction, what do they call that? Yes? Heart block, right? So it's going to block the conduction of the signal or the action potential on the two branches, the right bundle branch and the left bundle branch. If you're damaging or there is ischemia to the bundle of Hess, you will have a complete heart block. Right? You know what heart block is? Right bundle branch block, left bundle. No? Yes? موني وين موني؟ هو إذا سمع حينتحر الرجال مرة. إيش هذا؟ They teach this, right? No? Anyway, so ischemia of LAD, which is very common, you're going to end up with ischemia to the interventricular septum, and it depends on the severity. The wall of the ventricles might be affected, and if it is severe, there is a complete heart block or conduction block. The other artery is going to go around the heart in the coronary sulcus, it's called the circumflex. Before it goes around the heart, it's going to give us left marginal artery or arteries. Now from LAD also we'll have what we call the diagonal artery, or sometimes more than one diagonal arteries. Now as you can see, this is the circumflex. It's going to be in the coronary sulcus underneath the coronary sinus. Okay? Now, so the left coronary artery is responsible for supplying the left side of the heart, left ventricle, left atrium. Now the right, as you see, is coming from behind the right cusp, running in the coronary sulcus, giving us ventricular branches and branches to the atria, and before it winds around the heart, it's going to give us the right marginal artery. It's going to supply both surfaces of the right ventricle. Okay, this is the marginal, and then it's going to wind around the heart. Here it is. And it's going to anastomose with the circumflex of the left. But before it does so, it's going to give us this important artery. It's called PIA, posterior interventricular artery, or posterior descending. And this is the artery that will supply the posterior 1/3 of the interventricular septum. Okay, it does not reach the apex. Apex is mostly supplied by LAD. Okay, PIA does not reach the apex. It supplies the posterior 1/3 of the interventricular septum. Now, this is a typical picture. This is an 80 to 80% of us. Now, artery to SA node, you'll never see them. Arteries to the SA node, artery to the AV node, they are microscopic. You're not going to see them. But generally speaking, in 55 to 60% of us, artery to the SA node comes from the right coronary artery. It goes in the myocardium to the SA node, and in the rest it might come from the left or from the circumflex. Artery to the AV node, which is here, it comes from again also from the right in most of the cases, or could be the beginning of PIA. Here it goes to the AV node. Just remember that artery to SA node and AV node in most of individuals comes from the right coronary artery. Now, this is important. It's called the coronary artery dominance. So 80 to 85% of you, we have the typical picture, which is basically, right coronary artery goes around the heart, and it's going to give us PIA. And this is the left, LAD with circumflex. In 80 to 85%. In 15 to 20%, we have what we call the left coronary artery dominance. Basically, the only difference is that PIA is coming from the circumflex. Instead of coming from the right, PIA is coming from the left or the circumflex. And 5%, it's coming from both. Why does it really matter whether PIA is coming from the right or PIA is coming from the left? Who's going to answer this? Who cares whether it's coming from the right or it's coming from the left? It's going to bring blood, whether it's coming from the right or it's coming from the left. Why it is really important to know where the PIA is coming from, whether it is right dominance or left dominance or codominance. Codominance is fine, but why? If there is ischemia, you do angiogram, you inject the arteries with dye, and it will tell you where it's coming from. You will see where the blockage is. ها؟ مين الشاطر فيكم؟ ما حد شاطر؟ واي تفضل شو اسمك؟ عبد الرحمن. There is no left. We're right, we're right. أعطيك سؤالين عنه هذا ويمكن أسألك بعد. Why? مين قالت كيف Pia is supplying posterior third of the septum. Why does it really matter with the right or left? Left. Okay. And if it is from the right? Excellent. Now, look at the interventricular septum. What supplies the interventricular septum? Anterior two-thirds is what? And it is coming from right or left? And posterior one-third is pia. If pia is coming from the left and you have blockage of the left, you will have complete blockage, no blood supply going to the interventricular septum. While if pia is coming from the right, like 80 to 85% of us, then if LAD is blocked, then you will have blood supply going to the septum. It's not complete blockage. Clear? Okay, so you need to know that interventricular septum is supplied by two arteries. LAD, which is coming from the left, and pia. Pia could be from right or left. If pia is coming from the left, which is atypical, then the two arteries are coming from the left. If you have blockage of the left coronary artery, then you will lose blood completely to the interventricular septum. That's why it matters. While if pia is coming from the right, at least you will have some blood supply. Okay? Clear? Fine. So this is the area, this is the what we call the coronary dominance. Now, venous drainage, the heart, like any other organ, it has its own venous drainage, and it's mostly the coronary sinus, and it is running in the coronary sulcus. But the coronary sinus is being fed by three major veins, and it is important to know where they are located. One is great cardiac vein, second is middle cardiac vein, and the third is the small cardiac vein. And remember this, great will be with LAD, middle will be with pia, and the small will be with the right marginal. Okay, let's see. Now this is the coronary sinus, and it is basically a continuation of the great cardiac vein. Okay, this is the middle cardiac vein, it's running with pia, and this is the small cardiac vein. They all drain into the coronary sinus. So middle cardiac vein is with pia. Great cardiac vein is with LAD. And you can see it going up, and it's going to continue as the coronary sinus. Middle will be running with pia, and the small will be running with the right marginal going up to the coronary sinus, and you can see it coming from here, from the right, again joining the coronary sinus. So the coronary sinus receives three main veins: great, middle, small. Great with LAD, middle with pia, and the small with the right marginal. and they drain into the coronary sinus, which opens into the right atrium, okay? So all non-oxygenated blood, regardless whether it's coming from the heart itself or it's coming from superior or inferior vena cava, will go into the right atrium. We have some other veins, they go directly into the right atrium. We call them the anterior cardiac veins. We have 3 or 4 of them from the right atrium, from the right ventricle to the right atrium directly. And we have some microscopic veins. You're not going to see them. Basically, they might arise from anywhere and they will open anywhere. From the right ventricle to the right atrium, from the right ventricle to the right ventricle, and so on. These tiny, small, we call them the least cardiac veins, or vena cordis minima, and basically they are microscopic and you're not gonna see them. Now, this is an angiogram. Basically, they injected the dye through the coronary arteries. They go through femoral, right? And they go all the way up, abdominal aorta, thoracic aorta, and then into the arch, and then they inject the dye into the coronaries, right? So recently they go through the radial, axillary, and so on. They reach the heart and they will inject the dye. If the dye flows normally, then no blockage. Now here you can see there is a little bit of narrowing. So if there is a narrowing of an artery, what do? They go with the same catheter. They inject the dye. That catheter has a balloon. When they reach constriction, they inflate the balloon so it opens the constricted area. Sometimes they use like a blade to remove the fat or the atherosclerosis. If not, they will put the atma or a stent. Stent is basically like a spring, like this. And the idea is to keep the artery open. Then endothelium will be built on this stent, and the artery will remain open for a while. If too many areas need stent, they cannot do more than 2 stents, 3, 4 stents. If too many closures, they might need to do a bypass. What do we mean by bypass? Basically, as the name implies, bypassing the closure area or the injury. For example, this is an artery here. There is stenosis or there is closure here. You want to bypass this, do a detour. So they will bring a vein, long saphenous vein or the artery from behind your sternum, internal memory or internal thoracic artery, and they bypass the closure here. They stitch it to the aorta and they stitch it to the artery beyond the closure. This is called bypass operation, and this is an open heart surgery. It's a serious surgery, so they don't do that unless the patient is actually in need and there are many closures. Now, just a few words about that, and I don't know why Dr. Moni wanted me to stress on that, but this is a physiology thing, Heart, like any viscera, is supplied by autonomic nervous system, right? Autonomic nervous system supplies 3 structures: heart, and glands, and smooth muscles, right? Heart, glands, and smooth muscles. Smooth muscles, where do you find smooth muscles? Blood vessels, GI, trachea. Wherever you find smooth muscles will be supplied by autonomic nervous system, sympathetic or parasympathetic. Now similarly, the heart is supplied by sympathetic and parasympathetic, and these acts, sympathetic will come from the spinal cord, from T1 to T4. Preganglionic, they communicate with the ganglion outside the spinal cord, and then postganglionic neurons, they go and they send their axons into the muscle, onto the AV node, SA node, and onto the coronary arteries. What do? Sympathetic will increase the heart rate, increase the force of contraction, and will dilate the blood vessels, right? You know this by now. Parasympathetic will do the opposite. Parasympathetic is mostly vagus. Why do I care? Dr. Moin is going to talk about it. But I care about pain. Now, if you bring a heart and start cutting it, or cottering it, or burn it, or do whatever, or chew it, patient will feel nothing, right? Because it's a viscera, it's supplied by autonomic nervous system, does not feel pain, touch, and temperature, right? Like skin. Skin is supplied by somatic, it feels pain, touch, and temperature. Viscera will feel only distension or stretch or ischemic pain due to accumulation of metabolites. Now, do you have cardiac pain every day? You have ischemia every day? You have renal pain every day? You have gallbladder pain every day? Rarely, unless you have a condition. But you might have pain from your chest and the body wall at any time. Somebody touches you, somebody punches you, you hit something, right? So your brain is used to have signals from the surface of the body, right? And wouldn't know that you have pain from the heart, or pain from the gallbladder, or pain from the appendix. Any pain that comes from an internal organ, your brain is not that smart, will interpret it as if it is coming from the outside. Agree on that, so that you understand the concept of referral. Now, pain fibers from the heart, always, from any organ, they always go back to the spinal cord and then to the brain, hitchhiking with the sympathetic fibers. Always, remember that. So pain fibers, how do they have access to your spinal cord? They hitchhike, they go backward, they clamp with the sympathetic fiber. In case of the heart, the sympathetic fibers are coming from T1 to T4 or T5. Okay? Now, if you have ischemia, pain in your heart, blood supply is occluded, cells are dying, accumulation of metabolites, the patient is going to come with severe chest pain, sweating, whatever. Now, is he going to say, I have pain in my heart? Your brain is not using to have pain from your heart. So he's going to interpret the pain is coming from your heart as if it is coming from the chest wall. Now, the area of the chest wall that is supplied by T1 to T4, which we call them dermatomes, is this the area of your left chest and left shoulder. Okay? So if you look at the dermatomes here, T4, T3, T1, T2, T1 is that area. It is that area on the left. Right? So any pain coming from the heart, pain fibers is going to go back with the sympathetic fibers and enter the spinal cord at the level of T4 to T1 to T4. And your brain is going to interpret that as if it is coming from the chest wall area of T1 to T4. This is called referred pain. Now, similarly, if you have a kidney stone, patient is not going to tell you, I have pain in my kidney. He's going to say, I have a groin pain here, and it might even go down to your thigh. Why? Because the kidneys are supplied by nerve fibers that will hitchhike with sympathetic fibers that go to certain areas of the spinal cord that will supply that area and the thigh. So you will feel the pain as if it is coming from the thigh or from the groin. So heart pain, you will be felt in the left shoulder and the left side of the chest wall. Sometimes the right, because there is interneurons between right and left, they connect. But anyway, focus on the left in the area of T1 to T4. Why? It is called referred pain. Why? Because pain fibers, they go back with the sympathetic and they enter the spinal cord at that level where the sympathetic came from. So this is the concept of referred pain. Okay? Any questions? Good luck on your midterm on Thursday. It's going to be easy, inshallah, no worries. خلاص خلصنا. You have? Oh.